All right, thanks everyone. Like Brian said, I'm going to handle talking about why sprinting is important as a transition into return to sport. He's going to go over some really good practical implications and evidence on how to progress one back, and then Christa is going to give really good insights on return to sport criteria that you can use to make your decision. So regarding the hamstrings and sprinting, it's pretty important in performance. It's correlated with high stride frequency. So the faster you run, the higher your stride frequency is. So it does help with speed. The second point is really just saying the higher activation of the hamstring you have, the faster you move forward. And then you have the hamstrings work the most during late stance and late swing phase. Although those are the two phases with the highest EMG, the late swing phase does have 2 to 3 times more activation than the late stance phase. As far as injury goes, 81% of hamstring injuries occur while running. Of those running injuries, 57% occur at sprinting speeds. So the hamstring is pretty important in sprinting for both performance and injury. For the sake of time, I'm going to go over just the modifiable risk factors. There's also many non-modifiable risk factors. Of all these, they really found, Timmons looked at this, and I believe Freckleton in 2015 looked at these as well. But looking at relative risk factors, these are all the green highlighted ones that have shown to have some kind of risk with it, although it's mixed. I'm really just going to talk about eccentric strength and fascicle length, but more specifically fascicle length, because Chris is going to handle more of hamstring quad ratio, hamstring limb symmetry index, as well as a hamstring eccentric strength. So fascicle length is a pretty clear risk factor in hamstring injuries. It's usually measured through ultrasound taken longitudinally along the muscle body. What they found was in this group where they looked at the injured leg versus the non-injured side, they found that on average it was about 1.4 centimeters shorter at rest. And then when they measured the fascicle length during an isometric contraction, they found that it was again shorter, but to a less amount. And you can see the trend here in their relative risk analysis that there's a clear trend showing that the shorter a hamstring fascicle length is, or biceps femoris specifically, then the greater probability of injury you're going to have. And from that, they found that for every half centimeter increase, there was a 74% decrease in injury risk of the hamstring. And then for absolute length, they found that less than 10.56 centimeters resulted in a 4 times greater risk in injury. And so when we compare different modalities of increasing fascicle length, we can look at sprinting, Nordic hamstring exercises, which is pretty common too, or just playing your sport. And this was a recent study in 2020 that looked at a 6-week training program. So they had a sprinting group, a Nordic hamstring eccentric exercise group, and just a soccer group. One thing to be clear is all these were technically soccer groups. They all did 90 minutes of soccer, but the sprinting and Nordic hamstring group was on top of the soccer. So they were training for maybe about, I'd say 2 hours versus the soccer group that was training an hour and a half. They looked at a bunch of stuff, but for the sake of fascicle length, you found that there was a greater increase in fascicle length in the sprinting group. If you could see the percent change in the third column, you can see that there was an average of 16% compared to 7% in the Nordic group. And then if you're just playing, there was hardly any change there at all. So sprinting was shown superior in that study, but I don't think it's just because we're talking about sprinting, it doesn't mean we need to throw everything else out. It's just making a point that sprinting is important. I think a lot of people in clinic, they'll have them just go for a jog, have them run on their own, have them run in like maybe a 10-yard parking lot kind of deal. But I think it's important to get through a full progression. But saying that, it's important to add in the other stuff too. In this study, the protocol they have here is from Peterson. This is a 10-week Nordic hamstring protocol. But the actual data I'm taking is from Pollard 2019. This was a 6-week training program with Nordics. And what they found is right over that 6-week program, you started to see the fascicle length kind of return back to normal the second you take Nordics out. In this study, they did ask the players to continue their Nordics about 2 to 3 times a week, but they're unsure of the compliance. So even if you got the changes in sprinting, I do think it's important to keep Nordics in, because the group that went back to soccer, technically the Gurren sprint in soccer, but for some reason they were maintaining those fascicle length gains. So I think it's important to still include everything in there. And then more importantly, looking at the different exercises that people usually train for hamstrings, I think it's important, but again, nothing really simulates sprinting like actual sprinting. So you have the classic Nordic hamstring exercise. You guys have all seen it, but notice this one, it doesn't mimic the velocity that the muscle has to work through. And it also doesn't replicate the hip angle position at that late swing phase that most people get injured in. You can do variations with the isokinetic, so you can change different speeds and change the hip angle using the seat. But again, this is isokinetic, and it's not, it may not really relate to how people run in the real world. There's also the Russian hip extension exercise. So this does put the hamstring in a stretch position, but again, maybe this guy's underloaded, but I think it's pretty hard to heavy load this exercise. And again, that knee stays in a permanently extended position versus going through that full arc of motion through it. And then lastly, you have razor curls too. This is a good modification for your Nordic hamstring exercises, but as you can see at that bottom right corner, when you have the highest force in the hamstrings, again, that hip is in a extended position versus that flex position you see most people get injured in with the late swing phase. The last thing too is just getting in volume alone. So not only just choosing the exercise and intensity, but you want to sprint because that's the most, I mean, it literally is sprinting, and it's important to get the distances and reps in, which Ryan will go over. But if you're just hoping for the best and having people go out there, they might not adapt or tolerate the loads well. So if you can appreciate the graph on the bottom left in the light gray is the negative work of the biceps femoris on here. What they had in this was basically they had runners run 100%, and then they rated, and they were able to calculate people's 80% of speed. So if you look at the 80%, the work gradually increases up to 100%. But when you actually calculate it, even though their effort is increased by 20%, the negative work on the hamstrings is increased by 43%. So it's not just a linear increase, it's a pretty substantial exponential increase. So one, it's be cautious of how much you increase the amount of work someone does and effort and speed. But also, I think it's important to get through a lot of reps of these during rehab. So by the time they're out there, they can tolerate these high negative workloads on their hamstrings. And these are my references, go Deeks. And from here, I'm going to pass it off to Ryan.
Can everybody see that? Are we good on the PowerPoint, Vien? Can you see that? Give me a thumbs up.
I can see it.
Perfect. All right. You know, just with everything that Vien talked about, we wanted to then just offer some functional examples of what this might look like in a return to sprint progression here. So first, to understand what a sprint progression might look like, I think it's very important to understand what your typical population presents like and what do they run like in certain distances. So this is a really good study on football norms. And so what they did is they looked at a competitive running environment in D2 football athletes, and they had them run at 10, 40, and 60 yards. And what they noticed with this is that these players were, and this was true of all position groups, even your offensive tackles all the way up to like your cornerbacks, that they were all accelerating up until 20 yards. And that's when they reached peak velocity, but then they had a deceleration episode. So it's important to really understand what your typical patterns might look like in a specific population. This is different from a track athlete, which we'll see in the next slide here. So they essentially took that graphic, so this being your football group down here, this being your velocity, and they overlaid that with a track group here. And so typically a track athlete is going to peak more at that 60-yard mark versus a football player is going to peak more at that 20-yard mark. So I think this is important to know, because if you're coaching a athlete through return to sprint progression and they're a football player and they seem to be hitting their peak at 20 yards, that's normal. And that's going to be typical to know. They're not just kind of dogging it or peaking out like that. It's just a typical progression for that. And it's just very important to know that the overlay is just consistent throughout, no matter what the distance is. So a little bit of a hard graph to read here, but you can see from the X's that are marked, that's going to be at the 10 yards. So that would be here. And then the triangle marks, which are overlaid with the squares, which is hard to mark, is going to be the 40 yards. Whereas the 60-yard marks is just the squares. And so that's why that line gets there. So this is true no matter if they're running a 40-yard distance or 60-yard distance, you're seeing that pink at the 20 yards. So it's just good to know and informing you as you guide people through these progressions. Another very interesting recent article that came out looked at a pain-free versus pain threshold rehab group. And it was a randomized control trial. And so what they did, the variable was essentially allowing folks to progress through rehab either at a pain-free threshold or a threshold of 4 out of 10 pain at any point. So if the pain-free group had any pain, they would immediately shut down their rehab and basically say, come back later in the week, essentially. And the pain threshold was allowed to progress up to the 4 out of 10 threshold. And so what they found was there's no statistical significance in time to return to sport. So thus, the folks that were pushed through pain still returned at the same time compared to the individuals that didn't progress through pain. But of particular interest to note is that there was a greater recovery of isometric knee flexor strength in the 90-90 position. And so it's a very functional position where the hip would be flexed and the knee being extended out. And as Vien kind of spelled out, that's where a lot of these hamstrings, that's the highest demand that they have. And this point occurred at the return to play clearance as well as that 2-month follow-up time. And it's particularly interesting to note that at that 2-month follow-up time, these individuals across the board, both the pain-free and the pain threshold group, were reporting 0 out of 10 pain in that 90-90 test 2 months out. But it lets you think that by pushing through some pain, you had some more advantageous adaptations occurring earlier in the rehab and thus a greater strength gain later on. Another big takeaway from this article was that they had sustained improvements of that biceps femoris fascicle length at that 2-month mark. And Vien kind of detailed how important it is to have that fascicle length change. And I think that really just provides strong level of evidence for integrating a sprint progression, which we'll review that this article provided in just a second here, to really institute that fascicle length change, but also at the same time that there is going to be some type of pain associated with that lengthening, and that's okay and that's safe. And there's a lot of, this is a really good article, and there's a few other things that I just want to point out. They did report having an occurrence of an adverse event in that pain threshold group where a subject had 7 out of 10 pain during a sprinting session. And that session was then stopped. However, he was able to come back and complete another session 2 days later. And I think that just shows that, you know, as long as you're monitoring your athletes, basically the whole, it wasn't a re-tear, essentially. It wasn't a restraining of the hamstring, even though that they progressed higher than 7 out of 10 pain. The athlete was fine and able to come back after they simply said, okay, that's your capacity for today, come back. And then he completed that full session 2 days later. So I think the biggest take home from this article is that really you can push your athletes, explain to them what is reasonable pain and what's not reasonable pain, and they're going to end up with better outcomes potentially due to that. In this article, it also had it offered a progressive running program. So with this, you were completing 3 reps at each stage. So the most you would complete, because you're doing 9 reps a day, would be 3 stages in a day. And it was 2 total rehab sessions per week. So at minimum, this would take you about a week and a half. And I like this program because it does offer having some acceleration, some sustained speed, as well as a deceleration phase, as well as changing in speeds, which I think is important. to be able to volitionally do. And it has a lot of application to sports where somebody might be running and then they get the ball and then they run again, like in a soccer athlete. So changing speeds is important. However, I do think that at the most you'll see is that the most volume that you would have is 450 meters of total volume per day, and the most sprinting speed you would have is about 270 meters. So I think this program, if we look at norms and a D1 football player, we're correlating that. Now these are norms over the course of the game. I think it's going to be underloading these individuals a little bit. So we look at, a defensive back who's over 4,500 yards. If we're only having them sprint for 270 yards, sure, that rehabilitation program might only take 15 minutes to make, but for yourself, I think you're probably underloading that still. So I wanted to see what other progressions are out there. And so recently, Dan Lorenz has published this article in the Journal of Sports Physical Therapy. And it's a criteria-based return to sprint progression following lower extremity injury. Some hallmarks of the program is that volume is adjustable. Addition of cutting-based exercises are optional, especially towards the end of the rehabilitation. And as intensity increases, you're going to have a decrease in volume as well as an increase in the work-to-rest ratios to offset this increase in intensity. And we'll kind of discuss how I think that's basically allowing individuals to progress back to their prior level of intensity. Passive mobility and strength tests also serve as a prerequisite throughout the program. And so this is the first stage here. It occurs at 50% of intensity, and this is just a verbal cueing that you give the athlete. I want you to run at 50% of your speed. And as I mentioned here, it's specific to these work-to-rest ratios. We're going to see this individual has more time of rest as the intensity increases. But in this stage, when you're trying to build capacity during this stage, you're going to try to limit that rest to basically build muscle endurance and combat muscle fatigue. As you can see here, it's 4 steps per stage. It's starting lower down, and you have 940 yards total, which is progressing up to 1,100 and 120 yards total. And from this, it's a pyramid type of run where you'd start at 20 yards, working up to 100, and then coming down to 20 yards. If the athlete's not able to complete that, it's almost like a UCL-based rehabilitation approach where you just come back and try the next step 48 hours later. And the next step would be increasing that intensity. You're pushing that work-to-rest ratio higher to combat that, but at the same time, you're also decreasing volume, and that's something that is well done throughout this program, is you're accommodating that increased intensity by increasing that volume to be able to allow this athlete to achieve these steps. And as you can see here, we've built that capacity, and now you're trying to build up on that intensity, and that's why you're going down from that 780 yards to 560 yards. And then the final step here, or the final stage, I should say, at this, you're going to be cueing the athlete to run at that 90 to 100% intensity and having that 1-to-7 work-rest ratio. And I think what I really appreciate about this stage is going back to looking at the characteristics of, such as the example of a football player. Typically, they're only going to run 20 yards per play. So in this stage, you're cutting out those 80 and 100-yard runs now that you've built the capacity. And you're really trying to make this as applicable as possible to an individual sport here. And as you can see here, you're still limiting the amount of volume as you progress on, so you can increase that intensity. And once again, taking advantage of that 1-to-7 work-rest ratio to really allow your athlete to be able to accomplish this. And so I think Dan's on the call, and maybe he can comment on this, but I think this program design is more for like a traumatic hamstring injury or a post-operative return to ACL program after reconstruction. So what I did is I wanted to go in and modify this as maybe something that I would do in the case of a hamstring that is more on the grade 1, if you will, or a mild type program. Or a mild type injury. And so what I did is, realistically, the case that I was thinking of is if you have an athlete who on Friday night gets injured in a football game, has a acute hamstring strain. The next day you see them in clinic, they're able to walk, you give them some basic strength stuff, and then they come into you on Monday again and they're reporting that they're pain-free. So how are you going to progress them through this? So what I did is I took some of the stages. These two are from I took some of the steps from stage 1. These are step 1 and step 2 here. And then, just demonstrating how we're going from basically increasing the capacity here. So what I like to do in these cases is I'm taking the total load, multiplying it by the intensity to get I'm taking the total distance, multiplying it by intensity to get some rating of load, essentially. And you can see we're increasing that load from step 1 to step 2. So that, for myself, is we're building capacity. Then as we once again progress into this step 3, where we're increasing this intensity, going up to 75%, we're using those work to rest ratios again to allow them to achieve this intensity. But at the same time, we're looking at 0.7 times the total volume of running, and that's going to be 780. And you can see that there is a still total decrease in load. So that hopefully will allow them to get to that intensity there. And then you can see that we basically do the same thing as we progress on step 4. Another good point, I was talking with one of my colleagues, Sierra Berge, about this, but I think that in these milder types of hamstring injuries, you can start cutting early on. That's not usually a limiting factor. So what I did is I basically went in and demonstrated a program here where we're going to have an individual cut at the midpoint, this being the degree of the cut, occurring at the midpoint of 10 yards. So they'd cut after 5 yards and then run 5 more yards. And then just go through and just kind of describe how we're not only increasing the intensity of the cut, as you can see from this step to this step, we're increasing that degree of cut to 90 degrees in that 5-yard run, and then we're going to 60 to 75 degrees. This seemed logical for myself because when an individual is starting to run 5 yards, they're not going to be running as fast, so that cut's not going to be as intense. So I think it's smarter to introduce that more dynamic or aggressive cut of a 90-degree turn in those reps where you're only running 5 yards into the cut. And as you can see here, you can progress. So how I might institute this in a high school athlete is I might have them come in, go through this over 15 minutes, then give them a break. And that in my head is almost like, okay, that's a quarter volume there. And then maybe we're going through the cut program after we give them a break and allow them to recover and try to make this as sport-specific as functional as possible. In a D1 setting, you might be getting through these 2 steps, and then you might be having them go back to practice and going at 75% intensity through their drills, and then going to that 90, 100%. Gets back to just kind of the whole what is accepted risk as you progress through these athletes. So with that, just to summarize my presentation, I think it's important to know your norms, understand what you're working with, and what the capacity of these athletes are. Progressively work towards them, reverse engineer this, and design your program based on that. Monitor your athletes. Some pain is okay. It's just important to really know your athletes and look for those body language type signs too, if they are important. So with that, I think we're going to pause and open this up to any discussion among the group. Are there any other sprinting progressions that you've used post-hamstring injury? Are there any specific drills that you use? Or is there any way that you would monitor fascicle length in your practice currently?
Yeah, I just had a quick question for you guys. This is Daniel. Looking through that Hickey article, what are your hypotheses for why fascicle length would be greater in the pain group versus a non-pain group when they're still going through and doing eccentrics? And for the sprinting, when you guys are doing your sprinting progressions, are you going through and doing those with athletes that have pain? Is there a certain threshold that you're using?
So I'll start with the second question. For me, I think both the intensity of pain matters. So I would try I usually do draw it at 4 out of 10. And I did that before I read that article. That's usually my criteria, is no less or no more than 4 out of 10. And then I don't want anything that's too sharp in nature. It's okay to kind of have a dull ache throbbing. But for myself, I find that when you do get into those sharper things, that's when you can have an increase in symptoms or, potentially a setback to not progress through that. And I think athletes are pretty good at self-limiting that. Most of the ones that I've worked with, I think athletes become more and more aware of their bodies, more and more at work. So I think, basically trying to progress off that. As far as why the increase in fascicle length, I just wonder if it's strictly a physiological mechanism where you're having more, as you push through more pain, theoretically, maybe you're implementing more force through that. And because of that, you're having more of a shearing episode. And getting back to the kind of physiology talk that we had, you're just going to have more of a positive adaptation where there is a greater amount of muscle damage. And then you're going to have that increase in satellite cell proliferation, which would result in that increase in muscle capacity and potentially just maintaining those fascicle lengths to be longer.
Hey Ryan, so with the pain stuff, with exercises and more of resistance training, I'm more willing to let them work into their pain threshold. But with sprints, I'm not a fan of pain. What are your thoughts on that?
I do think some level of pain is okay in sprints, especially with the timelines that you work with. I think, I think the evidence isn't there that you're not necessarily injuring them again. I think some low level pain is okay. I'd be curious to hear other people's thoughts on it.
Niles raised his hand.
Sorry, my question was not necessarily regarding the pain, but more so specific drills. And I just kind of wanted to get y'all's thoughts, as well as maybe some people in the audience here, on are they doing, these are great sprint progressions and I really like them as well, but are you doing return to sprint like technique drills, such as like wall drills and stuff like that?
Niles, I do that. I do wall drills after most injuries, just as both exercise and exposing to load, but I do think it's beneficial that you can work on their mechanics too, and it also makes them feel like an athlete. So I'll start like wall drills. I have them have a dowel in back position, just do like lateral marches real slow to get it down for multi-directional work. So I personally like using that.
Yeah, I think oftentimes, and I didn't include it in here, but Dan talks about a sport-specific warm-up and breaking a sweat, and I'll often do those before you go on to that sprinting progression.
I'll chime in here quick too. This is Christa from UW-Madison. I've also found that track athletes versus field athletes, football players, for example, will respond or be interested in different levels of sport-specific sprint drill training. The football players are pretty eager just to get back on the field, and the track athletes are more aware of some of those sprint-specific drills. So then they're more receptive to some of those drills. And I think it just brings home the point that education in these athletes is huge. And honestly, not only education for the athletes, but also education for our sports rehab staff and the team, the strength coaches, because they're the ones who are working on some of these sprint drills with some of our teams too. So I think that's huge. And Ryan, Vien, I give you guys a lot of credit. I think you guys did a great job kind of wrapping up some of these sprint techniques or the sprint progressions, because I think sometimes a lot of these details get lost, and the sprinting and that return to high level function and sport, especially in these high level athletes, is huge. So I think it's an important piece that we all need to continue to focus on.
And we definitely want to move on because Chris has got a lot of great material. But I'm just curious, any other thoughts or opinions or experiences with pain-free versus pain threshold type sprinting, return to running post HSI?
I would say from this is Dan again. I would say just from a psychological standpoint, if you're doing a return to sprinting program and if an athlete reports a 2 out of 10 pain and you just immediately stop it, I think that can be a psychological barrier when they get back to return to sport, just knowing the fact that anytime they have pain, if you stop an exercise or completely modify it or take it out, I think that could be something that psychologically sets them back a little bit, versus if you just kind of decrease it a little bit, or you kind of just stay where you're at as long as you're within that threshold. So I would think that some pain would be okay. Obviously, you don't want that sharp pain, and it shouldn't be very high, but making sure that you don't give them the mindset that anytime they do have any type of pain, you're just completely shutting them down, I think is something to consider as well.
I would also argue the quality of the movement pattern too would be something to consider, because we know pain is so subjective for everybody that if they're reporting a little bit of pain, but their quality of movement and their push off and their stride looks pretty symmetrical, I'd feel pretty comfortable letting them continue to progress.
This is Pete Trayovich, and the only thing I wanted to add is that a lot of times I see people that try and teach people how to run that actually don't see enough of people as examples. So that front side mechanics is really important so that they don't get backside mechanics going. So if you're not familiar with running and you don't see a lot of it, get somebody with you to put some eyes on it so that you are teaching the right thing.
Hey, this is Kerry at Duke. I've a lot of great points, and I would agree with all of them. The other thing for me and painful running is I think you have to just be aware maybe what intensity you're at. You know, if somebody's non-painful at your 50%, 60, 70-ish percent, or very limited, very minor pain, I think that's fine. I think it's, and let's say then they get painful at their 90%. Is something in their mechanics changing, to Pete's point? And then, and what's that like? Knowing your athlete, obviously your track, your soccers, your some of those sports are going to typically run at higher speeds longer than a football player, especially your non-skilled players. And so I think just having that awareness and paying attention, basically.
One of the other things, this is Pete again, one of the other things that I've seen in football, and I work down here in Jacksonville with the Jaguars, one of the things that I see is especially receivers coming off the line. I saw that there's something for sports-specific drills, which might be covered in the next section, but guys coming off the line sometimes they'll have problems with the hamstring just because the isometric contraction and the push off and the battle positions they got to get in, just like an offensive lineman would too. So I start throwing a lot of that in when I'm doing the running drills as well, so that they've got a meter resistance coming off, because that's the last component that some people will sometimes complain of.
Perfect. Yeah, I'd be really interested to see any of that material. So if you could send that, I'll send it out to the rest of the group. That'd be great.
You got it.
So, all right, we're going to have Christa take over. Thanks again, everybody, and take it away, Christa.
Good morning, everybody. Give me a second here. Can you see that? Are we good? All right, awesome.
That's great.
All right, well, good morning, everybody. Thanks again. Thanks to Ryan and Vien. I'm really excited to be here to kind of wrap up some of these hamstring strain injury discussions. I've really been fortunate to be involved or in a lab that has this long-standing history of hamstring strain injury research. So hopefully I can share some of that wisdom and research over the years with all of you this morning. We're actually currently wrapping up another 3+ year study looking at hamstring strain injuries over time and trying to specifically add some novel imaging aspects and really dive into some of the functional and objective outcomes, not only at injury, but return to sport and some of the long-term changes too. So look for some more hamstring research from us in the near future. So my goals for today really are to try to wrap up some of these discussions we've been having over these last 3 weeks and to address a few questions that have come up. I really enjoy the discussions we've had during these sessions, so please continue to ask questions, jump in. I'll try to pause as we go with some specific questions for the group too, but don't hesitate to stop me. Ryan, Vien, chime in. I can't see the chat right now, so if someone pings a question, don't hesitate to stop me and we can address that as we go. So Ryan's done a really nice job touching on prognosis really a few weeks ago, but my goals for today, since we all are faced with this question from the athlete, from the coaches, from parents, the first question we hear is, when can I return to play? So I just want to wrap up, touch on that a little bit. And specifically, there were some lingering imaging questions, tissue-specific questions I'll try to address. Goals to then move into some return to sport decision-making, to look at the evidence or lack thereof evidence of the criteria we use to decide return to sport. And then finally, my goal is just to briefly touch on re-injury risk factors and how that return to sport decision affects that. So to kind of get us started, no surprise here, Ryan kind of already addressed this early on, but there really is limited evidence or limited strong evidence to predict the time of return to sport based on those time of injury findings. So a couple prognostic factors or indicators that are discussed that may be potential areas are pain, what the extent of pain is, both at time of injury, at return to sport, how were they injured, length or the volume, the amount of tissue injured. Some people look at tissue type specific, and then muscle injury grading or the severity of injury is also analyzed as potential prognostic factors. Again, I'll try to address a few of these here, but unfortunately, evidence doesn't necessarily point to one as the golden ticket here, which is why we all still have jobs in this field. So anyway, I'm touching on these muscle injury grading scales. I'm certain that each of us have seen a radiology report indicating that the grade of muscle injury or reporting the grade of muscle injury based on that MRI read. And honestly, we probably all, or I should speak for myself personally here at our institution, I see those muscle injury grades often without any qualifying factors, without a specific reference, without a specific scale. Sometimes it's just this arbitrary 0 to 3, and I don't even know, is it 0 to 3, is it 0 to 4? So I tend to have a little caution when interpreting some of those radiology reports, and I just want to address or specify, look at a few of these scales specifically here. So in front of you, you see 3 examples of hamstring strain injuries, a few details on each of those examples, and I'll go through a couple of these muscle injury grading scales specifically. So modified Petrin scale is 0 to 3. The image on the left is an athlete with no apparent signs of injury on MRI. So she would be qualified as a grade 0. Small amount of edema present on the left biceps femoris long head in that the next female soccer athlete, so she would be a grade 1. And then finally, our football player on the right would be a grade 2 on that modified Petrins. The British Athletic Muscle Injury Classification is another really popular scale. So again, grade 0. As we move across the right of that screen, progressively worse, which makes sense. So BAMIC is actually a 0 to grade 4 being complete avulsion, complete rupture. And then there's another subclassification of that BAMIC, which looks at tissue-specific involvement. So is it myofascial? Is it myofibril? Is it intertendinous? Is it the proximal distal tendon? So again, grade 0 on the left. Now we'd have a grade 1A representing the muscle fibers are involved in that case. And then finally, grade 3B on the right, indicating some of that intratendinous or conjoint tendon involvement in that athlete here. So there's been some nice studies that are comparing some of these muscle injury grading scales. There's moderate agreement across these scales, But unfortunately, the variance in the return to sport times between these scales is really all over the place. So again, just a word of caution when trying to base your return to sport time off of MRI alone. Again, there are some pieces, I mean, obviously that an MRI does have an importance. I'm not trying to sway that or change anyone's opinions here at all, that there is an importance and value of that MRI, especially when you're trying to rule out an avulsion of the proximal hamstring strain injury. So certainly value and place for MRI here. Some pieces or some of the evidence that does support some initial trends toward an increase in time to sport would be MRI positive versus MRI negative. But again, on that last slide, you saw that that female athlete had the largest or longest time to return to sport, even though she had an MRI negative injury. Oftentimes, there's some initial research that does support the length of injury, and we've talked about this a couple different times, but that cranial caudal length of edema present on MRI may be representative of time to return to sport. But again, important to be careful here because we know that gravity can affect that spread of edema, especially in that cranial caudal direction, depending on time from initial injury. And then there's some inconsistent evidence on the grading scales like we just reviewed, and again, some inconsistent evidence on tissue type involved. More specifically, there's some trends with some of that in conjoint tendon or intertendinous involvement. But again, that's debatable. Seems like for every paper I read on increased time when that conjoint tendon is involved, there's another paper that shows that there's no increase in time or effect on return to sport time with tissue specific. So again, just a couple examples. Here in the top right, you see obviously there's some muscle tendon junction involvement, whereas the bottom right in the corner there, that's more of a myofascial level injury between those muscle boundaries there. There's also a couple good papers that compare our clinical findings versus MRI assessment, and I thought both of these papers did an interesting and really a nice job comparing or trying to determine how much added value MRI adds above and beyond our clinical assessment. And really there's limited evidence that shows MRI adds a significant amount or changes our return to sport decision significantly. So the first study looked at the athletes' predicted or perceived return to sport time, and they relied on passive straight leg raise specifically with their clinical assessment. The MRI grading did not associate with return to sport times. And then that second study, the Wangstein one, looked at return to sport determined by clinical factors and history, and then the MRI on top of that really added only another 2% or an explanation for another 2% of variance in their return to sport times. But again, interesting to note that the really only 29% in that case you see, or about a third of that variance, is explained by these clinical and or MRI factors. So just brings back the point that, again, each of these athletes, each of these injuries are unique, which makes it challenging, but also a rewarding and interesting injury for us to treat too. So just kind of a take home or wrap up on return to sport. I know we've kind of touched on this over all 3 weeks that we've addressed this now. So hopefully this is pretty clear, but really we all know that our clinical evaluation should help guide that return to play, return to sport prognosis. MRI unfortunately adds little value. There's some strong evidence that some different quantitative MRI techniques are really becoming more informative and more useful in not only musculoskeletal, but also other areas of radiology. So stay tuned. I think that there's certainly room for MRI to provide additional guidance. I don't know that we're fully taking or pulling all of the information we can from those MRIs. So I'm hopeful that there is still potential there. But as of right now, some of the clinical interpretations that we're using are not necessarily adding anything more to our clinical evaluation of that athlete. I made another point here. I really think there's a challenge between statistical significance and what we find in the research and the literature versus clinical significance. Part of this is because, or for one example, in one of the studies, the muscle grading did significantly contribute to prognosis following hamstring strain injury, but the variance, when you start to look at the variance or the spread of the data, that, say, for example, a grade 2 injury resulted in 0 to 50 days to return to sport. Well, I can't necessarily tell my athletes, I'm confident, I'm 95% confident that your return to sport time will be between 0 and 50 days. And I think that's what brings into question hits home that the statistical significance versus clinical significance really varies. And I think that's a challenge in this translational literature, and not only for hamstring strain injuries, but across the board. So again, potentially worth considering MRI positive versus negative, maybe the size, severity of the injury, but again, how do you precisely quantify this? And stay tuned. I'm hopeful that there's some advances in technology and imaging that we may see to help with that. And then also, I think another really big challenge for this type of injury, for all injuries specifically, is how do we define return to sport? What level, what type of sport are we talking about? Is this athlete in season? Are they out of season? And that significantly plays a factor in who's influencing that return to sport time. Is coach dependent on that athlete to play in that game on Saturday? Or is it Christmas break and they don't need to rush back to track in the next week? Or, I think that plays a big factor into these return to sport times too. And oftentimes we don't see that level of detail or those assessments made in some of the literature we're looking at. So word of caution there. So finally, I'd like to pause and open it up just for a few discussion points here. Anybody here willing to chime in and share how often MRI might be used at time of injury in their practice? I know a lot of clinicians, a lot of clinics don't even recommend or get MRIs at time of injury. And then finally, curious if anybody consistently uses a muscle injury grading scale. If so, which one? What are you comfortable with? Welcome any input or questions here at this point.
I think in my experience in private practice, I would be shocked if anybody got a hamstring MRI, and I would say that wouldn't be very cost effective. I think D1 and pro athletes a little bit more so, but I think in like a typical weekend warrior population, not so much in my experience.
In our, we went over hamstring didactics a while ago, and one of our former colleagues mentioned that in pro sports, they have the resources to be able to do MRI, but it really doesn't tell them much as far as return to sport, just that they're injured.
I agree. That's certainly what we see too. Because we're doing some research, looking at some imaging, all of our athletes that get a sustained an injury will have an MRI, but that's not necessarily the typical approach to treating these injuries. As I also think it really varies. Most of us on this call, I believe, are from the US, but in Europe, in Australia, in other countries, MRI is much more prevalent, and interesting difference in practice there based on regions too. But all right, any other questions on that imaging or return to sport prognosis? So moving on, we'll transition topics here slightly. Once the athlete's progressed through the rehab and getting close to that return to sport, we'll take a minute here just to try to look at some of the evidence that helps guide our criterion-based return to sport decisions. So unfortunately, there's quite a bit of evidence that shows that there are persistent deficits and signs of injury at the return to sport time. We know that there's a decent amount of edema that persists at that time of return to sport, and there's also significant changes in fibrosis and scar tissue formation in a lot of our athletes that may persist 3 months, 6 months beyond that time of return to sport. There's also some pretty good evidence that we've shown in our lab that there's some atrophy, especially of the biceps femoris long head, which is one of the most common muscles injured in hamstring strain injuries. And there is notable weakness that is still present at that return to sport time. Looking at tissue mechanics specifically, we also see increased strain in that injured limb or in that injured tissue. And I think all of these points taken together really bring into question, is that return to sport criteria we're using good enough? So again, spoiler alert here, there really is limited consensus on the standardization of return to sport criteria. And I think the problem here is that current evidence supporting return to sport lacks some of that reliability and those, like we talked about earlier, those known meaningful clinical changes. And the clear relationship between that deficit at time of return to sport and the risk of re-injury is unknown. These re-injury events happen. We all wish they wouldn't happen as frequently, but because they're not as common as some of those initial injuries, it becomes harder to conduct research or monitor some longitudinal studies here. So this is what really makes that final return to sport and re-injury challenging. Common categories that I'll dive into a little bit more in detail with each step of this return to sport criteria are clinical evaluation, muscle strength assessment is obviously a huge piece of this, and then finally sport-specific functional testing as well. So clinical evaluation, some of the key points, again, I'm just trying to summarize some of the research and hit on the key points. We obviously could spend an entire lecture, an entire morning on each one of these things specifically, but the two key things across the literature are pain and range of motion that are important in your clinical evaluation. So absence of pain, pretty straightforward. Range of motion is expected to be symmetric and pain-free at return to sport. And a couple tests, we'll dive into these a little bit because they've come up over the weeks. First one is straight leg raise. Again, pretty straightforward. Hopefully everyone's aware and familiar with that. The next one I wanted to take a minute to look at is active knee extension test, and quick video here. I'll just annotate for the sake of sharing a YouTube video over a video chat. But here's one of the most standardized ways to perform this active knee extension test. The athlete is asked to pull their lower extremity into near maximal hip flexion and then actively extend their knee to their most comfortable end range of position there. And the clinician will monitor and measure the angle at that point or range of motion there. So again, here you're looking for the maximal degrees of range of motion and whether or not that athlete is having any pain or insecurity at that moment during that test. I saw a couple things come across the chat. Let's see.
I think Dan was bringing up what individuals might be doing in regards to like ASTIM or GRASTIN over the injured site during return to plane phases. I think my short answer is I sometimes stay distal away from the area of injury during like those earlier phases, not like, you know, maybe 2 or 4 weeks out. And then as you get into it, as you get into those later phases, maybe going a little bit over the site. I think a lot of the signs is showing you're having a little bit of a neuromuscular relaxation. So that's when I would use it. I don't know if you've seen anything like that, Christa, or anybody else.
Yeah, and I'm not going to touch on, I don't have any necessarily slides or evidence. So this is a great time to pivot and talk about this. So we do certainly use some of that instrument assisted treatment. I'm pretty, like you said, cautious with it early on, but a lot of it becomes athlete dependent too. and their trainer specifically what they're used to and what they're comfortable with, and you in some ways tailor to your patient at that case, in that case or that instance. And interesting when you have the MRI to be able to specifically identify, is that myofascial? Is it myofibril only? And then you can start to think about some of those specific techniques, and is the physiological change or advantage of those techniques applicable to the specific tissue you're seeing or the damage you're seeing on the MRI? I don't have, that's strictly anecdotal. I've played looking at some of that. I don't necessarily have research. I'd love to see that, but yeah, it's certainly a hot topic. Like Dan said, polarizing topic, but I don't have clear, straightforward answers there. All right, I'll talk about just one more test that's come up here. The Fascicle H test we've talked about. I think each week we've addressed some hamstring strain injuries. So again, just a quick video to make sure we're all on the same page here. So this is really a dynamic assessment of range of motion in its most standardized form. The athlete is stabilized at their waist and the contralateral leg, and oftentimes it's recommended that their involved leg is placed, or the leg being measured is placed in a knee immobilization brace to really try to lock that knee into full extension. And the athlete gets a practice round, and then they have 3 dynamic repetitions of that active knee extension, or in full lower extremity extension. And you can measure range of motion, and the studies that look at this, they use an electric or a digital goniometer. I don't necessarily have access to, well, we do, but in the clinical setting, I don't use that. It's more of the athlete's perception of, do they have any insecurity? You can do like a rough range of motion comparison, but do they have insecurity? Do they have pain when they do that Fascicle H test? So again, that Fascicle test looks specifically for that dynamic lengthening. It assesses pain and apprehension. It has shown some good reliability, and if you use the right instrument and measures, it is sensitive to detect differences in range of motion. And then outcomes here, how this is utilized for return to sport decision making. If the athlete reports insecurity or pain on a visual analog scale, then most people do not encourage return to sport at that time. The protocols that I looked up or referenced here, if they have insecurity or apprehension, then they'll continue rehab, and you can reassess the test in 3 to 5 days. And we'll touch on this towards the end, but there's some evidence that this test specifically may reduce re-injury risk, but it does increase return to sport time. So it becomes a balance, and some are critical that this may be too conservative in elite athletes. But again, that's all a discussion that you have with that entire team there. So again, I know there were a lot of questions. Happy to open this up now at this point. Pause. Looks like we got one question on chat, but anybody feel free to chime in here as I'm reading the chat question.
It's not necessarily a test, but I do think, and I think this is Tim Tyler's work out of New York, and I think it would be interesting to test somebody in not so much of a seated 90-90 position, but having them basically have one thigh off the edge of the table and like in a length and sprint position. So using a iso dynamometer, basically their thigh being only on the table of their lead leg that you're testing, and then that hip extended back off the edge of the table and like planted on the ground. I think that's just like a functional position, sports specific. I think that's just a little bit of a better position than just having them seated 90-90, both their hips flexed.
Yeah, I agree. I've seen that before too. That's a great point, Ryan. Yep. And I think Alex's point was on the chat is just making sure that, correct me if I'm wrong, Alex, but I agree, making sure that how you set that stage for what you're educating that athlete on is huge, whether it be a range of motion test, a strength test, whatnot. Make it specific, make them engaged and aware, and I think that's what gets you the buy-in here for those return to sport decisions.
Do you have any evidence from the literature of if you do the test and then they have insecurity or pain, do you have any information on what they do in those 3 to 5 days before they retest?
Yeah, so we'll circle back to that. There's a couple studies specifically that do address some of that. What's strongly recommended is that they're at that point when you're getting close to return to sport, you're in that functional phase, that sport specific phase of training. So that might mean you're continuing to work through some sprint progressions that Ryan and Vien talked about. It might mean that you're working on high level eccentric strength, or it might mean you're doing sport specific jumping, cutting, some specific things. So it's basically, there's, again, not necessarily clear this is the one protocol to use, but it's basically repeating or continuing that end stage of rehab and just preventing or minimizing, or I should say educating that athlete that they may not quite be ready yet for full return to competition. Maybe you're still allowing them to practice at 75% effort, but you haven't returned them fully to that last stage of competition. All right, so we'll kind of transition and move on to strength. Specifically, we really could spend an entire lecture on this alone, but I'll try to highlight some of the key studies here and really the key points again with strength assessment. This is really an important part in hamstring strain injuries specifically. We talked about this last week a little bit with some of the rehab recommendations, but we know, or we've seen a lot of evidence moving from that isometric to concentric to eccentric progression with these hamstring strain injury athletes, and I think that's important. And for your return to sport criteria, there's some pretty strong evidence that supports those dynamic strength deficits will persist beyond the isometric strength. So there is a pretty clear recommendation that there must be some level of dynamic assessment of muscle strength for return to sport in these athletes specifically. In terms of criteria, just general asymmetry criteria, there's actually a decent amount of evidence that talks about a less than 5% threshold for some of these specific measures. But when asked clinicians across the board, most clinicians say they use a 10% threshold. So something to keep in mind again there. Different methods to use for return to sport for the muscle strength assessment, obviously manual muscle testing. We're all familiar with that. Time, cost effective, but may not be as reliable or sensitive as we want. The next step might be a handheld dynamometry assessment. That's certainly more objective. Isokinetic dynamometry is an option, but again, high cost, lab-based. We might not all have access to that in a clinical setting. And a NordBoard or a Nordic hamstring exercise strength assessment is becoming more popular, reliable. It has been shown to be reliable, practical. Really, it's a field test, a field-based test that can be used, but the prospective validity of use of that NordBoard specifically in a hamstring strain injury population has not necessarily been vetted or fully validated. So I'll try to touch on some of the key strength assessments here. For isokinetic dynamometry, we certainly, there's different approaches. We all know this. You can use concentric, eccentric, or different ratios. Here's some of the most agreed upon or the most supported ratios and speeds. You can do both with concentric testing specifically, both at 60 and 180 degrees per second. It's recommended here you see that less than a 5% asymmetry. There's some work, Ryan introduced the thought of using knee flexion angle and peak concentric torques. Again, hopefully you're shooting for a between limb difference of less than 5 degrees, time to peak torque within 10% of that uninjured limb. Happy to go into detail there, but I'll just leave some of those specific values and tests as a reference for you there. And then finally, that hamstring to quad strength ratio is often looked at too, specifically that eccentric hamstring strength to the concentric quad strength. Again, less than a 5% deficit is what's been shown to be the best criteria here for progressing return to sport. One question, any insight why they look at the eccentric ham versus concentric quad at different speeds? Yeah, really the biggest thing there is just that the eccentric hamstring is most often tested at that 30 degrees per second, whereas when you're doing concentric assessment, it's closer to the 240 degrees per second. And I think there are some arguments there. I think it's a great question. You know, functionally, when we're sprinting, yes, the hamstring eccentric work during that terminal swing phase of sprinting is happening rapidly, but to fully assess that eccentric capability of that muscle, in an isokinetic dynamometry way, you have to slow that down in that eccentric setting. So I agree there's a big discussion or big argument about the isokinetic dynamometry testing and how functional or how relatable is that. But here, when you're truly trying to assess the maximum eccentric and concentric capabilities of the muscle, those are the values that are often used. Yeah, so a few more follow-up thoughts coming in on that too. Okay, so great, another good question came in on that hamstring to quad ratio. No, you're not necessarily looking for an equal 1-to-1 ratio of hamstring to quads. Again, I have a specific reference value in one of the later slides. I think the ratio you're looking for is closer to 0.5. But what you're looking for, or that 5% deficit that I have listed on the slide, that's limb to limb. That's between limb difference of that ratio. You want that ratio to be similar side to side, involved versus uninvolved limb. Good questions there. All right, so NordBoard specifically, again, I think there's a lot of potential here. We are using this quite a bit in our lab. I know this came up last week. It sounds like this is being used across the board in a lot of different institutions. It's great because it's practical. It's a field test to assess eccentric strength. We know that the Nordic hamstring exercise is crucial for these athletes. So this is a great way to assess that strength a little more objectively. It's quick, it's reliable. There is some really good evidence that it can be used to assess future risk of hamstring strain injury, but again, hasn't necessarily been fully validated for that return to sport specific determination. But I will say anecdotally, I'll kind of play a video here quick for those that haven't seen it. Very straightforward. There's just 4 sensors in those loops at the ankles. And here you can see the objective output that you're getting. You do get individual limb measures of max force, imbalance, average force. And how we do it, we give the athletes opportunity to warm up. You have 3 practice sessions or 3 practice reps on the machine, progressively higher intensity, and then we do 3 official tests, and we take the maximum test to determine max force values. So just to kind of wrap up, the final thing that's often used for return to sport criteria is some of the sport specific testing. And again, the literature really varies here. So it can be some of the sprint progressions that Ryan and Vien did a nice job going through. Obviously, we're all familiar with some of the different jumping or hop tests. There really, unfortunately, is no specific outlined return to sport criteria. So early on in one of the discussions, we heard some different treatment approaches with the different types of football players specifically, and I fully agree. We do some different approaches to treatment or rehab with our O-lines, different than our receivers as well. So that's certainly a good example of why and when this sport-specific testing occurs and position-specific testing within sport. But unfortunately, we don't necessarily have clear research or evidence that supports what we should be doing down to the position level. So things to look for or do in general here: acceleration, deceleration, change of directions. We all know that. I think Ryan and Vien did a nice job of talking about that near max intensity and speed. I think that sometimes gets lost. So we really push that home to emphasize the importance of that early on. And again, no clear boundaries or thresholds here, but the goal is no pain, limited hesitation, limited insecurity. So again, there's some evidence that supports sport-specific movements, some evidence that supports use of sport-specific testing based on the type of injury. So was that a stretching injury? Was that a stretching, lengthening injury, or was it an eccentric injury? And can you replicate that mechanism of injury to ensure they're safe to go back to play? And then some people try to quantify that. You have to have 3 complete group session training before you return to that full competitive level. But again, no clear consensus on how exactly to progress that criteria. So here's a few. I kept saying we'll reference those slides or those values in a little bit. I tried to pull 3 specific examples in the literature of some of these algorithms, because again, I've been saying all along, we don't have one clear algorithm that is fully supported by research, but I think these are good examples to work from. This is the Erickson article we've been talking a lot about. I won't go into much detail on these. They're here for reference for you. Here's another specific criteria, a little bit more we're relying on that isokinetic dynamometry from an article from Brian Heiderscheit, 2010. And here's another. I liked this one because it did provide a few more specific details, a little bit more recent criteria here. And they did talk, here you see some of those values specifically for that hamstring to quad ratio, about 0.5. Some more specific examples of different tests here again. And then this is what they also use. They continued this functional phase, the functional assessment, every 3 to 5 days until they were fully cleared or did not have apprehension, either with the ASCLings or any of these specific tests before return to sport. Any other questions on return to sport criteria specifically? I'll keep moving here then. I know we're over time here already, but just quickly, I'll try to touch on risk for re-injury and how our return to sport decision influences re-injury assessment. So we all know some of these non-modifiable and modifiable risk factors that affect those initial strain injury. And hopefully we're comfortable progressing to the return to sport now. We've talked a lot about that, but unfortunately, one of the most challenging aspects of treating these athletes is that at least 30% of these athletes will go on to suffer recurrent strain injuries. And there's pretty strong evidence, like we talked about, that there are persistent deficits at return to sport that will affect the re-injury. And I think, unfortunately, again, we don't have as much evidence here as we would like to clearly guide our assessment or our assumptions between return to sport and re-injury. But we started talking about this already. This was one study that I mentioned that relied on the clinical assessment and the ASCLings H test that provided the lowest re-injury risk. But again, that did increase return to sport times. And this becomes a decision that you have to make with your athlete, your coaches. Is that risk worth it? Another study that resulted in increased re-injury used clinical assessment and performance tests specifically. And then kind of the in-between, or what one of these review articles recommended as a moderate approach would be to rely on that isokinetic dynamometry in that case. Does that provide you a little bit of clinical assessment, a little bit of objective strength assessment, And is that maybe a better balance then between that return to play, return to sport, and re-injury rates? So again, caution, limited number of prospective studies. Unfortunately, not the best methodology in some of these studies. So definitely an area here for further research. So just to kind of wrap this up and take this home, we all know we rely heavily on our clinical findings, really focus on that functional-based progression that's sport-specific for that athlete that you're working with in front of you when you're determining prognosis, decision-making, and re-injury risk assessment. We talked about the limited ability to accurately determine prognosis, return to sport criteria, again, limited consensus, unfortunately, and for re-injury, we know that some of these persistent deficits might play a role, but clearly this is a multifaceted, multidisciplinary approach to determining return to sport times for these athletes. And again, I said this earlier, but I really think that's what makes this a challenging population to treat. The types of injuries are from the get-go are incredibly variable. I mean, you can't necessarily compare it to an ACL injury, for example, but ACL injuries have their own challenges to treating too, right? But in an ACL injury, you're always injuring the same tissue, the same location. But in a hamstring strain injury, you have different tissues, you have different muscles, you have proximal versus distal, you have different functional utilization of those muscle types too. So I think the variety here in the level and type of injury is what makes this a really challenging injury to treat, to research kind of across the board. So I'd open it up here just for a few last points of discussion. If anybody wants to stick around for a little bit longer, who would you say are some of the key stakeholders on that multidisciplinary team? I think we often at this elite level see pressures, non-medical pressures, to return an athlete at different points in their rehab. And how do you address that balance between re-injury risk and return to sport with these athletes? And then finally, in your clinical practice, what do you see as the biggest gap in the literature, or where would you like some of the evidence to focus? And happy to try to answer or fill some of those questions if I can. All right, well, I'm sure there are more questions, but I know we're over time too. So I know we don't have all the answers for treating these injuries, but please reach out if there's anything specifically I can help with. Hopefully you took a little something home today. Ryan, Vien, again, thanks for getting us all together and getting us going here. I'll stick around for a little bit if there's any other questions. Otherwise, happy Friday, everybody. Thanks for your attention and chiming in this morning.
Yeah, thanks everyone for being here. If there's any questions, people got to run. We understand. I think for myself, I feel like a lot of these injuries are pretty self-limiting. Like if an athlete isn't ready to go back, I feel like they're, especially it's interesting. You mentioned the track athlete versus the football athlete, and I definitely feel that football athletes, just in general, tend to be a little bit more aggressive than this rehab versus track athletes that are so meticulous and in tune with their bodies. But I'm curious if anybody has had that experience where, an athlete's symptom profile just wasn't lining up at all with what they were producing objectively, where the athlete was like, no, I can go back, but they were still just like really, low on the isokinetics or the isometric testing or anything like that. I'm curious to get anybody's thought on that.
Brian, I would say we see that all the time. And unfortunately, I think that's just adds another layer of variability to these injuries, is that there are other factors that influence how that athlete is handling that rehab. And I don't have a great explanation for why. I feel like that's even more the case in a hamstring strain injury specifically. And I don't have a great explanation for why. I think the general perception of an ACL tear is across the board not great, right? But a hamstring strain injury can be so variable that I think an athlete might have a misconception of how severe their injury is, and then that allows some of those other non-medical factors to influence their perception of their rehab. And without good education or without good objective criteria to help guide them, when you have it, great, but sometimes no matter what you do, you can't sway or change that athlete's mind either. So I think it's a great point. I try to handle it the best I can with objective criterion-based progressions, but any other tips anybody else has here, I'm all ears too. Well, we can kind of transition. Sounds like there's looks like there's a few questions or comments on the chat, specifically referring to strength assessment in the absence of isokinetics. Again, what other things can you use to assess dynamic strength? And I think, Danny, the best example I can give so far is that Nordboard eccentric hamstring strength assessment. That's probably the next best option that's used pretty frequently. Yeah, it sounds like other people are chiming in with that too. So that's certainly one option that gives a pretty objective but a appropriate balance between manual muscle or handheld dynamometry versus isokinetic too.
Would you be more apt to use, if you could only have one, if you're stuck on an island and setting up your own hamstring testing place, would you choose a Nordboard or would you choose isokinetic dynamometer?
That's a good way to look at that, or put that question into perspective. I think from a research, I think I would answer that question differently if I had only my research hat on or only my clinician hat on.
Right.
And I think ultimately, in the end, if I had to choose, I would probably choose the Nordboard, because I think it might be a little more functional and it's so much more practical that I'd have a hard time saying no to that. I think there are certainly limitations, but in a clinical setting, I think that Nordboard has some advantages for sure.
Yeah, I think another interesting thing too is, I don't think it necessarily applies to what are the limits of isometric handheld dynamometry, because if you don't have a Nordboard, you probably don't have this, but Vald has these force decks as well. And it's a split Vald or force decks, and Vald's the company that makes the Nordboard as well. And I have seen it where they put it on top of a big box, essentially, have the person lay supine on the ground, 90-90 hip knee position, and then they would go and pull in basically an isometric test, but maybe more of a functional 90-90 position, or a little bit more systematic too versus a handheld. You can always use a gait belt in the handhelds to kind of make that a little bit more specific, but I think that would be an interesting use if those force decks, if you're only getting one thing. I like the force decks because it's applicable to a lot of things, just not hamstring.
Right.
You can kind of pseudo into it a handheld dynamometer type kind of thing.
Yeah, for sure. And actually, we've kind of modified the Nordboard to do isometric and or endurance testing as well. You can certainly, the most common thing to do is just that Nordic eccentric exercise, but we've done where they're holding blocks, or they hold that incline position and try to hold an isometric contraction at that point as well. And then also you can assess endurance that way too, to encourage them to hold that position, or whatever position you're specifically interested in, as long as they can until they break too.
Yeah, and another thought I had was actually from Vien's slides, where he demonstrated the individual who was ridiculously strong and was able to do it in an isotonic fashion all the way down, all the way back up. That would be somebody, Vien, you said it wasn't occurring at athletic speeds, but I wonder if you provide some overload, like a weighted vest or something, that you can get those speeds up to being like that failure kind of eccentric type contraction as well.
Yeah, for sure. We certainly see that too, where these athletes are maxing out this Nordboard test, right? They can go all the way down and all the way up, and we do overload them too. It's a different test if you're overloading them, right? But they will increase the force output in their hamstring muscles when you do overload them. You just have to be systematic about how you do it and record that if you're comparing longitudinally over time too. But yeah, there's some different ways or different approaches to use that Nordboard, and I think that also is functional or a practical application of that device as well.
Yeah, and I do think there's some models out there of an individual making like a device that measures things like a Nordboard with only like $70 and like a handheld.
Absolutely. Yep. It's a pretty straightforward engineering device or design. So yeah, there are some other alternative options out there too.
Doesn't look as cool though.
No, that's true.
Yeah. All right, guys. I think we can end it. Thank you everyone for being on. Looking forward to Vien stuff next week. We'll send out emails, and big thanks for our kind of guest speakers that have come on, Christa, Lee, and Kevin. We really appreciate all the contributions to the hamstring series that we put on here. So everybody, you guys have a great rest of your week. Everybody stay safe, and we'll see you guys next week.
Thank you.